think we understand what we can test, germline or tumor. We understand why to test, whether it be germline or tumor. When do we test, Katie?
Well, as you alluded to, we're catching folks up right now. So all of these patients that have been in survivorship or multiply treated recurrent patients, as they come into our clinics, we're testing them now. But really, I think that we're moving towards at diagnosis. Once you know that someone has a confirmed diagnosis of an epithelial ovarian cancer, we're offering the opportunity to undergo genetic testing and importantly, hopefully genetic counseling as well. So you know at the beginning.
Right. And it's for a clinical trial and the
clinical trial. I mean, so as we said, from a prognostic standpoint, we have frontline clinical trials that would be informed potentially by knowing whether or not they have a germline BRCA mutation or not. And also, you feel kind of bad for these patients who have been out there for 10 years or 8 years, and you're finally testing them, and their families have been sitting around at risk for years. And I think I certainly have seen a family member come down with a preventable ovarian cancer who, if we had tested her, if we'd known 5 years ago, 10 years ago, we could have prevented that. So it's really critically important.
So do you guys use genetic counselors? Everybody needs to be counseled. Everybody needs to be counseled, but in my practice, the nurse practitioner can counsel, I can counsel, and I also have genetic counselors. Who's the best person to counsel a patient before testing?
You know, I think it goes beyond who's the best person. Okay. I think the critical issue is how many patients were missed opportunities to get the test. So even if you refer to a genetic counselor, about 30% of patients don't undergo testing.
I know, right?
And that's where the point of care testing at initial diagnosis is so appealing. And also going back to the tumor testing, my one concern, and I didn't mention this earlier about the tumor testing, is do we know for sure that there's not tumor heterogeneity that can affect a somatic mutation? Not necessarily the germline, you'd expect all the cells to have that, but perhaps a somatic mutation. But I still find that idea very appealing, and we'd be able to catch a far greater number of patients who have these mutations rather than waiting for the genetic counselor's appointment and for them to keep that appointment.
So Brad, before we go on, can I ask, we focus a lot on BRCA1, BRCA2, but we haven't talked about panel testing. And I'm wondering how many of you all do that, and why are we doing it reflexively?
What do you mean reflexively?
I mean that we said that we would test all non-mucinous or all, you said all epithelial ovarian cancers. Why are we doing that instead of family history and all of the the risk algorithms that we've done before?
Because family history and age of onset don't predict the chance of being positive. It's not a good.
Well, they're predictive.
They don't predict,
but they miss.
They miss such a high percentage.
Right. We have the data from Washington Pennington's paper that really nice, I think, was eye-opening to a lot of people that if you rely on family history alone, you miss 30%. If you base it on age, this is all a young ovarian cancer, right? But you have patients in their 70s who are diagnosed, and histology even, which some people really believe that it's only a high-grade serous issue. We've seen these mutations across, rarely in mucinous, but not zero.
But it's not zero even
in low-grade serous.
Yeah, low-grade, in mutroids, absolutely.
So it may not be related to the cancer pathway. Right.
Do you?
Coincidence,
I use panels.
I don't know. Me too.
Yeah.
We do.
So that's an interesting. So test early, panels, good counseling, but beware that if you refer to the genetic counselor, still may not get done. Test the tumor, test the patient for germline. Okay.
Panels are critically important now. As we now know, there's 3 other high penetrance genes, and maybe 4 if PALB2 actually comes into there. They're low frequency, but you're not going to find them if you don't do a panel test.
Right, if you don't do
and those are patients whose families we counsel in the same way that we counsel a BRCA patient. So you want to catch those. You want to catch those 1 to 2%.
You can do customized panels now, so you don't have to do the full panel. If you want to avoid detecting a gene of uncertain significance, and what are you going to do with that gene, right? Is it the term that they've used is actionable, and while it may not be the best term, it does apply to the situation where patients get told they have a variant or they have a gene of uncertain significance, but we don't know what to do with that.
Correct.
That causes a lot of distress.
Right. Well, I think that's very helpful. Thank you for discussing genetic testing and the molecular biology involved in ovarian cancer.